Morning, everybody. Thanks for giving up a beautiful Saturday morning in New York to be with us here. I'm just going to give you a heads up if you're expecting a debate with fireworks like either last year's election or last century's debate between Jane Curtin and Dan Aykroyd. We're not going to deliver those sort of fireworks. I actually happen to agree with very much of what Carla had to share. But I do have a couple caveats, so let's move forward here. If I can figure out forward. Okay, these are my disclosures. And you'll see a little bit of duplication, not a lot. So two caveats. First caveat, before I embark upon a 10-minute infomercial on novel agents in follicular lymphoma, is that the focus of this discussion is on patients with high-risk follicular lymphoma, as Carla very carefully defined in her analysis of the NLCS. These are early progressors. And as she pointed out, in other confirmatory trials, this represents the panel of patients who, from the University of Iowa Mayo series and validated by a Lyon, France series of patients. This is survival for patients who are high-risk, early progressors. These dotted lines represent the normal age-adjusted survival expectations for those populations. This represents a demonstration of the survival for patients who were not early progressors. And this is data, generated largely in the first decade of the 21st century, and it suggests that with agents that were available as of 2015, if you're not an early progressor, your survival at least matches, or essentially matches within statistical power, that of the expected age and gender matched populations. So novel agents are not required necessarily, nor are clinical trials necessarily required for people who have good early outcomes. So the focus of this discussion is specifically for folks with high-risk disease. Second caveat, I'm going to apply what has now been termed the Rutherford-Leonard Bench-Smudge paradigm on comparative populations. So it used to be this conversation started out with selection, selection, selection. Now we have a fancier name and a really nice, useful diagram to go with it. I refer you to an editorial that Sarah Rutherford and John Leonard had in Blood just this week or last week as it related to a retrospective analysis of expected or benchmark populations, if you will, in highly refractory large cell lymphoma, anticipated then to be used for future phase 2 studies in that population. And what they point out is that whenever you're comparing an intervention retrospectively or concordantly, but not in a prospective fashion, to an observation population, you're going to have inherent bias from selection. Within any population, there's going to be patients who are less favorable, patients who are more favorable, just as there are in high-risk follicular lymphoma patients. Some of them are more high risk, some of them are less high risk. If you then ask them to go on to an intervention, the more complicated, the more time-intense that intervention is, the more likely you are to select from this end of the spectrum, and less likely you are to select from this end of the spectrum, which means that you potentially develop a bias towards a better outcome the more involved your regimen is. So we have to be a little bit careful when comparing the excellent data we just saw, comparing populations of patients who underwent autologous transplant for their high-risk follicular lymphoma compared to historical representations of folks who hadn't undergone transplant. Now, I want to know where you 42% are in the world, right? So pre-survey, the answer was 42% of you said, boy, I got a high-risk patient population, I recommend autologous transplant. So this is the current, or the best known data on the current practice for second-line therapy. This also comes from the National Lymphocare study. This is the same population of patients that generated the curves that Carla showed you. So out of about 2,700 patients, 900 of them, as of 2015, had undergone second-line therapy. So first of all, not a lot, but about 900 of them had undergone second-line therapy after a median follow-up of 8 years. And the choices are are depicted here. 31% used rituximab monotherapy as second-line therapy, 40% immunochemotherapy again, with the minority of that being rituximab and an anthracycline, followed by rituximab and an alkylator, followed by rituximab and a purine analog. The green selection represents chemotherapy without anti-CD20 antibody. And this red line, this 2% number, represents those people who went on to autologous transplant as second-line therapy, or as part of their second-line therapy. And for comparison purposes, the gray is radiotherapy, but the purple with 5% is radioimmunotherapy. So many more people underwent radioimmunotherapy than autologous transplant. When we did an analysis looking at early progressors versus non-early progressors, at the time, Carla's data and analysis wasn't known, so there wasn't much of a difference in the choices between early progressors and non-early progressors. But still, only 3.5% of early progressors went on to get autologous transplant as part of their second-line therapy. So it's easy to say we're going to choose autologous transplant as second-line therapy, but in reality, that's not what we as at least the United States community has been doing of late. Okay, so for the purposes of this argument, what constitutes a novel agent? Well, for this discussion, approved therapy that was not available or implemented in the first decade of the 2000s when the above survival data was generated. So we're going to talk a little bit about IMiDs. We'll talk about targeted kinase inhibitors. Inferred in all this is novel anti-CD20 antibodies, and in theory, we could discuss checkpoint blockade agents. Okay, so IMiDs. Thalidomide, obviously the focus here is going to be lenalidomide, and a lot of speculation as to what pomalidomide would do. This diagram very carefully depicts exactly how IMiDs work and exactly what they target. And what we know is that lenalidomide, as an IMiD prototype, combined with anti-CD20 antibody, is very effective in upfront therapy. Carla showed you some data from Nathan Fowler and MD Anderson, suggesting very high response rates and comparable PFS compared to antibody combined with other chemotherapy agents. And then more recently, in a multi-center cooperative group setting, the Alliance 50803 study looked at lenalidomide plus rituximab in 100-plus patients with upfront follicular lymphoma advanced stage. And similar to the other chemotherapy regimens, overall response rates were very high. Complete response rates in this setting, as reported by John Leonard at Lugano, is actually quite high. And again, this slide isn't meant to tell you which of these is better than another, but it's intended to point out that this is very active, with 5-year PFS of 70%, comparable to 2-year PFSs of 80% for the chemotherapy agents. Lenalidomide plus anti-CD20 antibody is also highly effective in relapse therapy. The GALEN study, which has been described at Lugano by Frank Morschauser, is probably the best representation of that activity. GALEN is a phase 2 study of obinutuzumab and lenalidomide on a monthly basis for about 4 to 6 months, followed then by maintenance of obinutuzumab. In relapsed refractory follicular lymphoma rates not otherwise specified, 86 patients, overall response rate 74%. 1-year PFS 76%, pretty active. Frank also described a small number of early progressors, 24 early progressors from this study. So take it for what it's worth, but the overall response rate again was 71%, not notably different than for the relapsed follicular lymphoma patients as a whole. CR rates about 40%. And similarly, among other chemo-refractory patients, overall response rate was still 60%, suggesting, well, maybe these novel agents, maybe these targeted agents won't have the exact same paradigm of being less useful in high-risk, early progressing follicular lymphoma patients. What about PI3 kinase inhibition? So that story really started for you as clinicians in 2014 when idelalisib was granted accelerated approval for patients with relapsed follicular lymphoma after 2 prior systemic therapies, largely on the basis, again, of a phase 2 trial of about 125 patients with heavily pretreated low-grade lymphomas. Not all were early progressors, of course, with response rates approaching 60% and duration of response of about a year. Well, and I apologize, the bottom of that slide went on to say that story slowed down quite a bit when a year and a half later, safety issues became a little bit more apparent, and special precautions and a deceleration of the study of idelalisib. But idelalisib is not the only PI3 kinase inhibitor on the block. This is meant to pictorially describe the activity of PI3 kinase, but really what I'm highlighting here is the fact that there are over a dozen PI3 kinase inhibitors in development. So what do we know about PI3 kinase inhibitors in early progressors? Well, the same trial that was published in the New England Journal of Medicine and went on to lead to the approval of idelalisib was recently updated in a recent report by the authors in Blood, which they retrospectively went back and specifically looked at about 36 patients who met the definition of early progressors. And again, just as had been true for the unselected population, the overall response rate approached 60%. The CR rate in this case was pretty modest at only 6%, but a duration of response also of about a year. Again, suggesting an uncoupling between that paradigm that says that early progressors are going to have a less effective outcome than late progressors, perhaps with targeted therapies. More recently, within just over a month ago, I guess now, there's been another PI3 kinase inhibitor approved for the treatment of relapsed follicular lymphoma. That's copanlisib, based primarily on a phase 2 trial, I believe entitled Kronos 1, reported by Martin Drayling in a very recent JCO publication. Now, again, in early progressors, Martin described at AACR an overall response rate of 60% for copanlisib, with a CR rate, again, modest at about 14%, and a duration of response, again, of close to a year. Again, highlighting that notion that in early progressors, again, these agents are quite active. BTK inhibition in high-risk follicular lymphoma, our best information comes from the DAWN study, phase 2 study in immunochemorefractory FL, 2 prior therapies, again, about 100 patients, and here the waterfall plot depicts a little bit less robust activity and overall response rate of 21%, but certainly some biologic activity. So which strategy is best? Are any of them good enough? We don't know. Carla gave you what I think is a very important answer. S1608 is the next intergroup trial looking at high-risk follicular lymphoma patients. As she pointed out, everybody with bendamustine and rituximab who progresses within 2 years, meeting the definition of high risk as defined for this debate, will get randomized either to an oral PI3 kinase inhibitor plus obinutuzumab, lenalidomide plus obinutuzumab, which is essentially the GALEN population, or what probably most of us in the room have historically considered in the past might be a standard of care of CHOP plus obinutuzumab, although data on outcome from this arm is actually strikingly absent. Primary objective is only complete response, not how long can the patient live or even necessarily how long can they stay in remission, but how active are these to get patients into response, after which, as Carla pointed out, autologous transplant is certainly fine. So in closing arguments, high-risk follicular lymphoma, bad hombre. Conventional strategies, as defined from before 2010, lead to poor outcomes in multiple studies. The status quo is not acceptable. Novel strategies are imperative to try. PI3 kinase inhibitors have intriguing activity. IMiDs have intriguing activity. And stem cell transplant, from my standpoint, is very rationally considered a novel therapy. And you can do it after you get your response from IMiDs or PI3 kinases, so you don't technically have to choose between Carla and I. And importantly, if we want to be any smarter as a society a decade from now, we really need to incorporate clinical trials with novel settings as standard operating procedure into this setting of high-risk follicular lymphoma, not necessarily for all follicular lymphomas.